that. Looking at those questions was fun, and hopefully illuminated you on maybe some of your knowledge gaps or how awesome you are, because you all are awesome. I want to do some introductions. So we have two experts in women's health here with us today, Addie Bardolph and Megan Williams. So look through the gallery and find their faces. They are both prior graduates of our residency program and currently work at the Women's Health Care Center at Roosevelt Clinic as primary care internists. And so if that's a career path that is potentially in your future, you should definitely reach out to them. But otherwise, I'll turn it over to them. Addie, do you want to share your screen?
Sure, yeah. Hey, everybody. Okay. Portion of screen, okay. So, how's that looking?
Looks great. Okay.
All right, so we'll just jump in since we have, I think, an hour, is that right? Okay, and before we start, I just wanted to say just a quick note that for the purposes of this talk, the questions do refer to individuals with the vagina, cervix, uterus, ovaries, and/or breasts, and they by default use she, her pronouns. And we wanted to acknowledge that not every patient with this anatomy uses she, her pronouns or identifies as a woman. So just to kind of recognize the limitations of the default nomenclature for this review. So question one, so the first question was asking about a 33-year-old woman who's coming in for a 10-month history of bilateral diffuse breast pain. It's severe. It occurs about a week before her menstrual cycle and resolves afterward. She has generally lumpy breasts, but no dominant masses and no nipple discharge. She has regular menstrual cycles, drinks coffee in the morning and again at noon. No medical history and no family history of breast cancer. On her physical exam, she has normal vitals, BMI is 29. Her breast exam shows dense nodularity in the upper outer quadrant of both her breasts without skin changes. She has tenderness on exam of both breasts, and then there's no evidence of lymphadenopathy. So pulling our group here, what is the most appropriate next step in management? Let's see here. Is my screen now showing the poll or, okay. Should I give my answer? Just wait, okay.
There, nice.
All right, okay. So we've got some votes for B. Let's see, how do we get the poll out of the, just to be able to go back to the slide?
You can just
close it.
Just close it, okay. So most votes for B, but some votes for C, D, and E as well. All right. Okay, so moving on. Yeah, good job. So advised use of a well-fitting bra. So this question is asking about cyclic mastalgia. And so the kind of key point that we wanted to clue you into is that cyclical breast pain, and generally actually breast pain in general, is tends to be a benign condition. And so to recognize cyclic mastalgia, so it's typically diffuse breast pain, so affecting not just one focal area of the breast. It's pain that comes and goes and often is worse before the menstrual cycle and then resolves after the end of the menstrual cycle. And these symptoms tend to be self-limited, so they don't require any imaging or medication pharmacologic treatment. And imaging, as I mentioned, not recommended, but if any patients are having mastalgia, including cyclic mastalgia, but they have focal abnormalities on exam, that does warrant imaging, further imaging, and we'll get to that with our next question. But again, treatment is going to be conservative, so just education, reassurance, appropriate breast support, and then NSAIDs or acetaminophen are appropriate second-line agents. And then there is not any evidence that reducing your caffeine intake improves cyclic breast pain, mastalgia. So drink away on your coffee. Any questions on that before we talk a little bit about features of suspicious breast symptoms? Okay. So thinking just generally about breast complaints. So I kind of made a table here to talk about features that are going to be a little bit more red flag versus more benign. So we just talked about cyclic nostalgia being less suspicious, and that the management is reassurance, education, well-fitting bra. So you'll see those in that first column. So diffuse breast pain, as opposed to a focal breast lump. I think that's intuitive to most of us, that a focal breast lump is going to be more suspicious. Breast pain that comes and goes is going to be less suspicious than pain that persists throughout the menstrual cycle, or a palpable mass that persists throughout the menstrual cycle. Tenderness on exam tends to be less suspicious than a painless palpable breast mass. And then I was kind of surprised to learn in kind of working with patients with breast complaints in the women's clinic that nipple discharge is not always a flag. Physiologic galactorrhea or nipple discharge can be milky, and nipple discharge that is bilateral and involving multiple ducts tends to be less suspicious than nipple discharge that is unilateral, bloody. So just asking about nipple discharge definitely helps us to kind of categorize symptoms that patients are having, but nipple discharge in and of itself is not always suspicious. And then even to recognize that women who have nipple discharge that is physiologic can actually have a variety of colors of discharge. So that could be clear, white, milky, could be even blue, gray. And so those colors, while they might sound a little alarming to us, are actually quite normal, but bloody discharge is really that flag to watch out for in a MKSAP question. Or in a board review question. So, and then of course, thinking about a well-circumscribed mobile mass versus one that is sort of stuck on or has ill-defined margins. Lymphadenopathy is going to be more suspicious. And then lastly, younger patients tend to have benign breast conditions compared to older patients.
I have a question about that.
Okay.
About what is considered older versus younger.
Yeah, so it's a little bit subjective, but in my kind of thinking, certainly women 30 and under, I tend to have much less suspicion for a malignant etiology for a palpable breast lump. And 40 and over, my sort of alarm bells start to go off a little bit more. 30 to 40 is going to be a little bit more of a gray zone. But in general, the vast majority of breast complaints in a woman 30 or under are going to be benign. And then again, 40 is when I start to think more about a malignant cause.
Two more questions. Lucas wants to know what is meant by a well-fitting bra. I might counsel a patient on that.
Great question. So gosh, Megan, how would you answer that? I think that might be intuitive to people who've worn a bra. Oh, sorry.
I think both of you are muted now.
I don't know. Is that better? Here, how about all unmute? There we go.
Okay.
That's better.
Okay, sorry about that.
Should I talk? I don't know.
Yeah, we can hear you when you talk.
Great. Abby and I are sitting like across from each other, so it's just a little bit tricky with the sound. Yeah, well-fitting bra. You can just ask folks, are there like gaps between the cup and your skin? Does it provide support? Do you feel like when you move around, like the bra is shifting a lot, or is it like staying in place? Besides that, I don't know. And Cameron said you might ask them if they ever had a professionally fitted bra. That's exactly what we do. We often send folks to get a bra fitting.
Great question.
Okay, and then maybe last question, how do you distinguish multiple ducts versus single duct?
Oh, so to many people who've never lactated or never had nipple discharge, the idea of there being multiple ducts is kind of a surprise. But it's really hard to say other than the nipple itself. The nipple face has multiple small openings. And for women who are breastfeeding, for example, patients who are breastfeeding, the breast milk comes out from multiple of those small ducts on the nipple itself. Whereas, a malignancy that is draining to the nipple will really only have a discharge from one duct, or could. That would be more suspicious. Sorry, that's not a great answer to that question. I'm really just restating. Does somebody have a better way to explain that?
I think sometimes on exam, when you are trying to express discharge, you can see like discharge coming. If it's coming from a single duct, you can actually see it because it will only have like one origin versus multiple ducts. You can see it coming from, you can actually see the discharge coming from multiple ducts on the nipple.
Great, thank you. Should we move on from that one? And then maybe if we have time at the end, we can come back to other questions. Okay, question 2. Okay, this question is a 44-year-old woman being evaluated for a breast lump she noticed a week ago, no nipple discharge. She birthed 2 children, the first at age 25 years, and her menstrual cycles are regular. She has no family members with breast or ovarian cancer, no medical problems, and takes no medications. On exam, she has normal vitals. Her BMI is 28. She has dense tissue bilaterally without skin changes. A mass is noted in the upper inner area of the right breast, measuring 1.8 centimeters. It's firm, mobile, non-tender with ill-defined margins. There's no evidence of axillary, cervical, or supraclavicular lymphadenopathy. She has a normal exam otherwise. So next, most appropriate diagnostic test. Okay, so we've got some votes for diagnostic mammogram. We've got some votes for diagnostic mammo and ultrasound. Okay, so it looks like most people wanted to just do a mammogram. So let's move on to the correct answer, E, diagnostic mammogram and ultrasound. So I did actually change this question a little bit just to make it a little bit more tricky. So if you were thrown off by this, that's okay. It was a hard question. And meant to kind of elucidate the imaging that we do for patients with a palpable breast mass. So key point, choosing the correct diagnostic image for palpable breast mass. So again, using those age cutoffs I mentioned on the last question. So age under 30, really diagnostic ultrasound is going to be your test of choice. And the reason for that is younger women have increased breast density. And so the sensitivity of mammogram is going to be much lower. And so for patients certainly over 40, diagnostic mammogram is going to be the test of choice. And we actually follow that with an ultrasound as well. The mammogram evaluates for calcifications and density, whereas ultrasound evaluates for characteristics of a lump, for example, cystic versus solid features. And so the two together are much more sensitive than one alone. And if you chose just plain mammogram first, that wouldn't necessarily be wrong. I just wanted to kind of bring up that what was the next best step in management. So mammogram certainly would have been appropriate for this patient who's over 40, but we also do want to add the ultrasound component to it for better sensitivity. So people in that sort of gray zone, age 30 to 39, either ultrasound or mammogram as a first test is appropriate, and it sort of depends on the radiologist, sort of culture or practice there. But again, mammogram tends to be the first test for patients over 30. So really looking for that 30-year-old cutoff as whether you're going to reach for ultrasound versus mammogram as your first test. But for women over 40 who have a suspicious lump, and you saw some of those same features we talked about in the first question, we would move forward with imaging with both a mammogram and an ultrasound. And then just as a caveat, pregnant patients, we use ultrasound, avoiding the minimal amount of radiation in mammogram. And then lastly, MRI, it can be helpful for screening purposes for women who might be at elevated risk for breast cancer based on a family history or personal history, but it has no role in diagnostic evaluation for palpable breast mass. Questions about that before we move on? I think one of the, there was not an answer choice for biopsy, but really just to remind everyone that we would want to do more screening before we would move to biopsy. And there are different types of biopsies. So fine needle aspirate, cord needle biopsy, or surgical and excisional biopsies. None of those are appropriate until imaging is done. So if you see that as an answer choice, you do want to get imaging to kind of confirm the characteristics of a palpable breast mass before you'd move on to biopsy. And FNA tends to be used for cystic lesions. So that would be in younger patients, usually who have characteristic cystic lesions on ultrasound. And then FNA, if it resolves a cystic lesion, no further workup is needed. And then core needle biopsy would be the typical biopsy of choice for a patient over 40 with a confirmed suspicious mass on mammogram and ultrasound. With a solid component to it. And then surgical excisional biopsy is used less often, but is used when the core needle biopsy could be technically challenging based on where the lesion is, or if the imaging and pathology report are discordant.
We have a question about any cases when you would not add on the ultrasound after the mammogram.
Clinically, I don't. I order them both together, mammogram and ultrasound. Sometimes the imaging, the radiologist will, just like when we're ordering like an MRI of the brain, the radiologist will decide based on the features that they need X type of imaging as opposed to Y type of imaging. But for us in primary care, we don't really make that decision. And so in general, I order both for anybody over 40, and actually in our practice, or at least for me, Megan, you can say otherwise, anybody over 30.
Thanks. Yeah, me too.
Other questions?
I think we're set.
We're good? Okay. Number 3. So menopause, hot topic, if you will. So we have a 49-year-old woman seeking therapy for 6 months of increasing hot flashes, now happening 6 to 8 times a day. She has night sweats occurring 3 to 5 times a night, and it's resulting in decreased sleep and daytime fatigue. She had her last menstrual period 14 months ago. She has no personal or family history of ovarian or breast malignancy. She takes no medications, and she has a normal exam. Next most appropriate management for this patient.
Addie, there was appreciation for your menopause time in the chat room.
All right, vast majority want B. And you're correct. So let me get out of that. So hormone therapy with estrogen and progesterone. And I think people are picking up on the fact that this person has a uterus and the progesterone is needed for endometrial protection when using estrogen therapy. And we'll talk about that a little bit now. So vasomotor symptoms of menopause. So hot flashes, also known as hot flashes, hot. So systemic estrogen therapy is indicated for and is the most effective treatment for moderate to severe hot flashes of menopause. And in general, this is something that we initiate in women who are aged 50 to 59 or within 10 years of onset of menopause. And menopause is defined as absence of menstrual periods for 12 months. And this patient had no periods for 14 months. In general, the transdermal or the patch is preferred over oral therapy. It avoids first pass metabolism, and therefore much lower doses are delivered using the transdermal estrogen patch, and therefore is lower VTE risk. And I think it's actually about a 1/20th the dose of the oral version administered in the patch. And then our goals with HRT obviously are symptom relief, but using the lowest effective dose for the shortest duration possible, usually 5 years or fewer. And that is a very patient-centered conversation in terms of risks and benefits. Contraindications, thinking about pregnancy, any unexplained vaginal bleeding, liver disease, coronary disease, stroke, VTE, breast cancer, endometrial cancer. And again, some of these are not absolute contraindications for hormone replacement therapy, and we're really having patient-centered conversations around this, given that vasomotor hot flashes can be very impairing. And then so remembering that for patients with intact uterus, we combine estrogen therapy with progestin. And there's a couple ways to do this. One is a sort of cyclic, so an oral progestin every day. For the beginning of the month, usually 12 to 14 days at the beginning of each month, or continuous, which could be in a combined transdermal preparation and a daily oral progestin, or a levonorgestrel IUD actually works just fine for endometrial protection, since its mechanism is thinning of the uterine lining. So that endometrial overgrowth that we worry about with unopposed estrogen therapy is counteracted with levonorgestrel IUD like Mirena or Kylena or Skyla. And then I just wanted to say that up to 50% of women experience hot flashes during menopause, but they do generally resolve spontaneously within a few years. So as awful as they are, and we do need to take them very seriously, you're not necessarily signing your patient up for, treatment forever. So most do resolve within a few years. And then just one other point when thinking about menopause, there's no routine laboratory testing that we recommend for diagnosing menopause. It's really a clinical syndrome, 12 months in the absence of menstrual periods. However, patients who have early menopause really should have pregnancy excluded and a lab evaluation for secondary causes of amenorrhea, including thyroid levels, FSH, and prolactin levels.
I had a really quick question about menopause, and particularly vasomotor symptoms, because it's two. The first is that sometimes I've seen, and maybe I'm just wrong, but sometimes I've seen people use like SSRI, specifically sertraline, for these vasomotor symptoms. And I'm wondering if you do that in your practice, what would be the distinguishing factor between that versus like hormonal therapy? And if you could speak a little bit about some of the like mood changes that seem to happen for women amongst menopause. And again, if we should think about treating those with SSRIs versus, hormonal replacement therapy.
Yeah, two really good questions. So the first one was about when to use non-hormonal treatments for vasomotor symptoms. And my next slide gets into that. So actually, let's just go on to that. So those would be for people who have contraindications to hormone replacement therapy, as I mentioned in that first slide, or for people who have mild symptoms that are not significantly impairing. So again, those vasomotor hot flashes have to be moderate to severe to be an indication for systemic estrogen. Very commonly we use SSRIs, SNRIs, gabapentin in my practice. Do you as well, Megan?
Mm-hmm. Yeah.
So very, very commonly, they are not as effective for vasomotor hot flashes, but certainly for people who have the mood overlap, this can be a really great option and can be continued long-term without any of the same risks. I haven't specifically recommended sertraline compared to fluoxetine or citalopram or escitalopram. For whatever reason, I'm a fluoxetine prescriber, but for our older patients, sertraline is used more often because of its lower med-med interaction potential. So I think that's really appropriate for somebody you're considering an SSRI for. And then just to speak to the mood question, certainly one of the symptoms of perimenopause is mood changes, low mood, mood swings. And actually HRT estradiol will help with some of the mood changes from that sort of fluctuation in estrogen levels as you progress through menopause. But mood alone is not an indication for HRT. So if somebody is not having significant vasomotor symptoms, I would choose an SSRI as opposed to systemic estrogen therapy. Does that answer your question?
Yeah, that was awesome. Thank you so much.
Yeah, no problem.
Okay, Addie, before you talk about genitourinary syndrome, John wants to know if you have recommendations about how to stop estrogen therapy.
Yeah.
What symptoms show improvement?
Yeah, so really yearly, we should be reevaluating use of systemic estrogen therapy because of its increased risk after 5 years for breast cancer and increasing risk of VTE and stroke in women as they get more distant from menopause. So each year talking with women about their symptoms, could they attempt to come down on the dose of their systemic estrogen. And for women who are using the patch, it's actually really nice. I learned this from a gynecologist at Harborview that you can just literally cut the patch. So you can even start by cutting like 1/8 of the patch off. And then you could stick with that for a month or even a couple of months, and then gradually cut back the patch until you're using less and less. Most of the patches are twice weekly patches. And then the actual dosage, you can change the actual dosage in the patch as well. So if that's easier than cutting, then you can just lower the total estrogen dose in the patch. And, typically we do that on a slow taper. We don't recommend just kind of quitting cold turkey. And then for the oral estradiol, it really just is a matter of lowering the dose formulation on kind of, I don't know, maybe like a month or a couple of months kind of time scale.
Yep, that sounds good.
Yeah. And then lastly, just to touch on genitourinary syndrome of menopause, and then I got to kind of motor through our next question. So this is going to present with vaginal dryness, dyspareunia, dysuria, frequent UTIs. And for these patients, genitourinary syndrome alone, again, not an indication for HRT. Certainly systemic estrogen does help with this. But topical preparations of estrogen are a first line, and that includes tablet, cream, or ring. And the tablet and the cream are a twice weekly maintenance therapy, and the ring or E-string is one of the brand names for that, is inserted intravaginally every 3 months and remains in place for 3 months and then is replaced and can come out for intercourse and just periodic removal if desired. So sorry, that was just kind of a brief touch on that. Certainly lubricants are recommended too for anybody who's having dyspareunia as well. Let's get to vaginitis. I want to give Dr. Williams a chance to get to her questions too. So this question is a 39-year-old woman with a 3-week history of malodorous vaginal discharge. She had antibiotics 3 weeks before the onset of her symptoms. She's monogamous. She has no medical history. She takes an OCP. She has a normal physical exam. Getting to the pelvic exam, she has a thin, homogeneous, grayish vaginal discharge with no adnexal or cervical mission tenderness. The rest of the exam is unremarkable. Her lab testing shows a vaginal pH of 5.6, and she has a negative whiff test. Which of the following is the most appropriate test to confirm the diagnosis? Okay, we have some votes for D mostly, and then a few for B and E. So let's move on. And D, saline microscopy. Was there an E?
No, there's no
There's no E in BV, you guys. So we're talking about BV in this question, bacterial vaginosis. So thank you, Meg Williams, for adding this fish for our fishy odor. Cute little icon there. So what is BV? It is an increase in the vaginal pH that contributes to an overgrowth of Gardnerella vaginalis and other anaerobes. So no one particular bacterium defines bacterial vaginosis. And it requires 3 of the 4 of the following: an elevation in vaginal pH above 4.5, thin and homogeneous vaginal discharge, a positive whiff test. So that's applying a KOH to vaginal secretions, and that results in fishy odor. And clue cells comprising at least 20% of the squamous cells on a wet mount preparation. So saline microscopy was your right answer there, as that's going to diagnose the clue cells piece of this. And just remembering that more than half of BV cases are asymptomatic. So asymptomatic bacterial vaginosis does not require treatment. We'll commonly find this on cervical cancer screening, suggestion of vaginal flora shift. And in the absence of symptoms, this is not something that needs treatment. I'll just show you a slide with clue cells here. So these are vaginal epithelial cells. You see this sort of like fried egg appearance to them. And then these are studded with the Gardnerella bacterium or coccobacilli. And so you'll get this sort of almost blurring out of the borders of the epithelial cells. And oftentimes it'll look even more impressive than this. So really a bright, almost like fuzzy or like TV snow appearance to them. And then just thinking about vaginitis generally, so we won't go through this whole table, but thinking about sort of the 3 commonest causes of vaginitis, certainly not exhaustive, but bacterial vaginosis, vulvovaginal candida, or trichomoniasis. So thinking about clinical presentation, this person had sort of the classic malodorous discharge. And these patients tend to actually be relatively asymptomatic in terms of itching, pain, bleeding, compared to Candida, really have a significant itch, irritation, dysuria, dyspareunia, same for trichomoniasis. And then the discharge on exam for vulvovaginal candiditis is going to be more of that increased thick white discharge compared to trichomoniasis, where you have sort of like a thin discharge and that classic strawberry cervix. So that's like a testable physical exam finding, I think. And then thinking about pH, so we just talked about how a vaginal pH will be elevated in BV, but as well in trick. And then for Candida, we'll have a normal pH. And then we use the whiff test. That KOH whiff test will be positive in BV, negative in the other 2. And then looking at saline microscopy, we talked about the clue cells. And then for Candida on a KOH wet mount, we would see the classic hyphae or pseudo hyphae. And then for a confirmation of the diagnosis in general for trichomoniasis, so a wet mount is going to show the trichomonads, but you can also use a nucleic acid test, as we do for gonorrhea, chlamydia, either vaginal or urine testing. And then lastly, thinking about treatment. So we won't talk about the treatment doses and courses here, but metronidazole is going to be your treatment of choice for both BV and trick. And then you can also use oral clindamycin for BV. And for vulvovaginal candidiasis, very common after antibiotics. They tried to trick you with this one, but fluconazole oral is probably what we use the most clinically here, and that's a correct answer on a test question, but you can also use vaginal azoles. Questions on that?
Nothing's popping up on the chat.
Okay.
I have a quick question. For BV and candiditis, do you also use one-time metronidazole, or is it different dosing?
So metronidazole I would not use for Candida. I would use that for trick or BV. And for trick, there is the high dose 2-gram dosing for trichomoniasis. And if that is not effective, then you can do the twice daily 500 milligrams for 7 days, as we do for BV.
Thank you.
Pretty quick. One other question. Do you ever use the metronidazole gel?
I do. I just find that it's, less convenient for a patient. If patients prefer a gel to an oral antibiotic, that's perfectly fine. And that's the correct answer on a test question. I don't think they would offer you oral metronidazole or vaginal metronidazole on the same question, but either one is correct. But in my clinical practice, I just do oral. All right. Dr. Williams is going to take over and I'll watch the chat.
Okay. Can you switch this?
Yeah.
Hi, everybody. Okay, so question 5. Let's get to it. So we have a 34-year-old woman at a follow-up visit for blood pressure control who hopes to become pregnant and would like to stop her oral contraceptive. She's not a smoker, no alcohol use, no illicit drug use. She's in a monogamous sexual relationship, has no history of STIs. She's got hypertension, type 2 diabetes, and depression. She's on the OCP, lisinopril, metformin, citalopram, and Tylenol as needed. And she has a normal physical exam. So in addition to starting folic acid, which of the following medications should be stopped at this time?
Are others seeing the poll? I'm not sure it's up.
Sorry, I'm gonna get rid of that. Oh no, I closed it. I think I messed that up. Sorry, everybody. Okay. Remove it. Yeah. Okay. 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 So pretty much everybody said C, lisinopril. We had someone vote for E. I'm really curious what E is. But yeah, oops. Yes, we want to stop lisinopril. So key point number 1, some key components of preconception counseling. So I like this little mnemonic flight. And so the F, you want to check in about folic acid. And so for the purposes of the test, it's 400 to 800 micrograms a day is how much patients should be on. Iron supplements are plus minus, they can help with anemia, but they're not technically necessary. The L is lifestyle factors. So the question gave us some information about this patient. She is not a tobacco user, or she doesn't have any alcohol use or substance use, but that's just a subset of things that you might want to check in about lifestyle factors. Infection and immunization. So just making sure vaccinations are up to date. And that especially pertains to thinking about varicella and rubella, because those are live vaccines and then also can have some congenital effects. And so if your patient, if there's a question of whether or not they have immunity, you can send titers. And if they aren't immune, you should think about giving them the vaccination and then give them advice to avoid pregnancy or try to avoid pregnancy for a month after they receive the vaccine. Other things to think about: risk for STIs, travel plans, Zika risk. Genetics is like a pretty broad thing just to throw out there, but in general, if there are any red flags that make you think the patient could have a genetic predisposition for something, you could send them over to genetics if they're open to that. Health conditions is just kind of a broad overview of what their medical history is. So for this patient, again, with them diabetes and hypertension and depression. And then teratogens, which that is kind of a big piece in and of itself. So that brings me to key point number 2, is just familiarizing yourself with some commonly used meds that have the potential for teratogenic effects. So I grabbed this table from the MKSAP to review with y'all. And I don't think that most of us have all of these committed to memory. So it's not something that I think you should feel like you need to have memorized in your clinical practice or for the boards in particular, but it's just helpful to call out a couple things. I think ACE inhibitors and angiotensin receptor blockers, like everybody identified that as something to stop. So those are pretty well recognized. Other things to be aware of that, statins, that surprised me when I learned about statins. That's contraindicating pregnancy, regular NSAID use, not great. A lot of psychotropic meds like lithium. And then if your patient is on like an anti-epileptic, either for epilepsy or for mood, like valproic acid. And then I have this little pearl down here in the corner because I just wanted to call out, I thought it was interesting that MKSAP includes SSRIs in this table. And that in the question, the patient was on citalopram, but that was not the correct choice. We wanted to stop lisinopril. So I was a little bit surprised to see SSRIs in this table. And I, just as a comment for your clinical practice, you do not need to just automatically stop SSRIs in patients who are on them, who are considering pregnancy or become pregnant. The one to watch out for is Paxil. Paxil, there's a questionable correlation with cardiac defects during the first trimester. And it's not like great evidence for that, but it's enough so that if someone is on Paxil, that's the one SSRI you want to watch out for and potentially think about switching them. And then I'm going to ask Addie to put a link in the chat from Mass Gen. They have a Center for Women's Health, and this website has a really nice synopsis of SSRIs and potential risks during pregnancy, mainly for the baby, and they're pretty minimal, which is why we don't automatically tell people that they have to stop their SSRIs, but just in the interest of like full disclosure for patients, like we can talk them through some of those things that that might happen, so that we don't have to go into that, but it's a great resource if you, yes, yeah, if you are looking for that for your clinical practice. Any questions?
We're doing great.
Cool. Okay. Moving on to question 6. So we've got a 37-year-old woman who's evaluated for contraceptive advice. She's married and has a 1-year-old. Her child was an accident because she often missed taking her previous oral contraceptive. She's got regular periods, but they're heavy. And in that regard, it's bothersome. She's got an unremarkable medical history. She drinks a glass of wine every night, smokes a pack of cigarettes daily. She's got a pregnancy test that's negative, and she's not ready to stop smoking, but maybe we'll consider it at a later time. So, which of the following is the most appropriate female contraceptive option for this patient? Okay, 95% said C, progesterone containing IUD. And then I think we had a vote for D, the mini pill. So let's get into this. I wanted to make a couple points for this question. One is contraindications to combined hormonal contraceptions. So estrogen plus a progestin, which is the pill, the patch in the ring. Because again, in this patient, they called out a couple different pieces of her history that make a combined hormonal contraception a contraindication for her. So high point, so breast cancer, immediate postpartum period. So typically it's really the first month, but the true contraindications where you really want to avoid it is in the first 21 days.
And just to interrupt a second, is that from elevated VTE risk, or is that related to breastfeeding, or what's the?
Yeah, the true contraindication is related to VTE risk.
Okay.
And there is some thought that it could decrease the milk supply, but that is something more that you could have a conversation with the patient about. So it's in the first 3 weeks, really the first month, your risk of VTE is higher, and especially in the first 3 weeks. And so speaking of VTE, a history of DVT is a contraindication. And I put a little star there because I don't know that you would get tested on this, but if someone's got a family history of a first degree relative with a DVT, that is not a contraindication. It's a personal history of DVT. Certain components of a history of diabetes, so not if you're a patient with diabetes, they can have combined hormonal contraception. It's just if they've got microvascular complications or they've had diabetes for over 20 years. Migraines with aura, various components of vascular cardiac risk. We don't have to read all through those. Tobacco use in someone who's over 35 and smokes more than 15 cigarettes a day. A complicated solid organ transplant. And I have to admit, I don't quite know when they say complicated, like what that entails. And then lupus with a positive or an unknown antiphospholipid antibody panel. So I also put a little pearl in this picture because this is not necessarily related to the boards, but I just wanted to walk y'all through in case you've never used the CDC MEC app. It is really helpful in your clinical practice. If you're not somebody who can just commit all of these things to memory, then that's what the app is for. And it's free, and it lets you choose by multiple different fashions, but I often use the MEC by condition. And so just as an example, if you clicked on that and you could go to hypertension, and if you click on hypertension, then it gives you all these options. You can look at to sort through that more. So if you've got a patient who's got more like uncontrolled hypertension, and they also have a definition for that to make it a little bit less vague. So maybe somebody systolic greater than 160 or diastolic over 100, then combined hormonal contraception is a 4. Which is a stop in the sense that the cons probably outweigh the pros, or unacceptable health risk is what the CDC calls that. Okay.
Do you happen to know why transplant's a contraindication?
I don't.
I don't either.
Yeah,
That's
a great question.
Just one question for you. Why in this case with the patients, why would the mini pill not be the best answer?
Yeah. So let's go back to that. One other thought for the question of solid organ transplant. While I do not know, there could be an answer in the app. So often if you click on that condition, then they will try to list evidence under that. And so that can also be helpful if you've got a patient who's got like migraines with aura and you're telling them it's contraindicated level 4, and they're like, okay, but why? And you have somebody that wants the evidence and you click on that, then it will tell you like it increases your risk of stroke by 4-fold, although the absolute risk is really small. So, okay. And then question about why not the mini pill? I think like just going back to this question. So this patient is someone who said that she had her first kiddo was an accident because she often missed taking her previous OCP. So there's actually a couple pieces in this history. I think I'm gonna, you know what? I just realized whoever asked that question, I'm gonna answer it in my next slide. Sorry. So let me go through those, and then if we don't answer the question, we can come back to it. So, so for this key point 2 really quickly, because this could be like a whole talk in itself, as all these questions could be though, but the ability to guide a patient toward a contraceptive choice that aligns with their preferences. And so just a couple of things to touch on. When it comes to the pill, some benefits are that you can have decreased painful periods, decreased amount of bleeding, and then also symptomatic ovarian cysts. There's many more non-contraceptive benefits that can come with the COCP, but those are just a couple that I called out. The downside is that you've got to remember to take it every day. And then if you're doing the combined one, there's the contraindication to estrogen. If you opt for the patch or the ring, so still combined hormonal contraception, but you get those non-contraceptive benefits of like decreased painful and heavy periods, but you don't have to remember to take it daily. So that could be a little bit helpful if you've got a patient who doesn't want to have to remember that. And then to call out the long-acting reversible contraception, the LARCs, you've got your Nexplanon and then your IUDs. And they're highly effective, partially because there are no issues with adherence and there's no estrogen in either of those. So they're an option for somebody who's got contraindications to combine hormonal contraception. And then calling out the levonorgestrel IUD in particular, this can help with decreasing painful periods or heavy periods, which is you may or may not get with the Nexplanon. And so going back for this patient, the two things to call out in this history, she often missed taking her previous OCP. So then she had an unintended pregnancy. And then her menstrual periods are regular, but heavy, and not just heavy, but bothersome to her. So from a preference standpoint, you might want to avoid a mini pill number one, because she's got to remember to take it every day. And with the mini pill in particular, she's got to remember to take it like at the same exact time, or pretty much the same exact time every day. And the mini pill doesn't necessarily help with heavy periods. And again, heavy periods in and of themselves are not necessarily pathological or have to be treated, but this question stem is telling us that they're bothersome to her. So the levonorgestrel IUD is a nice choice for her, because it addresses that medical contraindication piece, because she smokes and she's over 35. So it avoids estrogen for her, but then it also means that she doesn't have to remember to take something every day, and it can help with her heavy periods.
Thanks for answering that. And just to say, there was a comment in the chat that Annie mentioned she was reminded by pharmacy that patch BMI over 30 is a contraindication for the patch.
Yes. Although that too, the studies around that, we don't have to get into that, but there's an arbitrary cutoff of 198 pounds in those studies for contraindication for the patch. And so I have had patients where they really want the patch for one reason or another. And you can also have shared decision-making with the patient around that. Like the efficacy is probably decreased, but we can't quantify that. And is it better for you to use the patch than nothing at all if you're seeking contraception? But that is an excellent reminder. Thank you for calling that out. Okay, question 7, abnormal uterine bleeding. So we've got a 45-year-old patient with heavy menstrual bleeding. Specifically, it's heavy, it's unpredictable, variable flow and duration for the last year. Last period was 12 days ago. She's got a history of a provoked DVT. She's a current smoker with a 10-pack year history. She does not want to stop smoking. She's never been pregnant, and she does not want to become pregnant. She's got a normal physical exam, and labs show that she's anemic with a low MCV, a negative pregnancy test. And then she's got an evaluation for secondary causes of abnormal uterine bleeding, including endometrial cancer, and that is negative. So in addition to oral iron supplements, which of the following is the most appropriate management? Okay, so we've got some votes for B and C and D. Endometrial ablation, oh, and so kind of a spread, except for E. No one chose E this time, but the majority said a levonorgestrel containing IUD, and then endometrial ablation versus MPA. Okay. Oh, we've got 5 minutes, so I'll try to be mindful of the fact that we're running low on time. So it's a levonorgestrel IUD is the right answer for this one. And how can you be fast when we're talking about abnormal uterine bleeding? I actually really struggled to make these slides because there's just so many different places to take a conversation about abnormal uterine bleeding. Just
Maybe we
thinking,
can concentrate on this one and
Yeah.
insert question 8 just to give this the time that it deserves.
skipping osteoporosis, Addie Bardolph. That sounds good. Yeah, so we don't have to rush through it. Okay. So I think I was just trying to pick out some high yield things for abnormal uterine bleeding, especially as it's illustrated in this question. And so piece number 1, like what is abnormal uterine bleeding? So broadly, it's just uterine bleeding that is of abnormal quantity, duration, or schedule. So typically quantity is more along the lines of like heaviness, like if it's really heavy bleeding, which is subjective, but if it interferes with the patient's life or job or emotional well-being, that is one way to say that it's probably abnormal quantity, like abnormally heavy. And then duration is like just especially long, like if it's about 8 days or more, that's considered abnormally long, or schedule. So it's either happening too frequently or too infrequently.
Unpredictably.
Or yes, or unpredictably, thanks, Addie. So a framework, kind of just a nice way to think about it is POM coin. The first 4, polyp, adenomyosis, leiomyoma, and malignancy or hyperplasia. Those are like structural causes of abnormal uterine bleeding. And then the coin are non-structural things. And so this question in particular, the high point is that this patient is having what sounds like anovulatory abnormal uterine bleeding. So ovulatory, those are regular menses, but it could still be abnormal if your periods are like really heavy or really long. Anovulatory is the periods are usually meeting that abnormal uterine bleeding definition because of the schedule. Like you can't predict it. They're coming sometimes like every 2 weeks or 2 months or 3 months. So that indicates that there's probably a lack of regular ovulation. There's a lot of reasons why patients could have that bleeding pattern, but I just called out some common ones are thyroid dysfunction, PCOS, and hyperprolactinemia. And Addie talked about this in her past slides, but it's what we really worry about is endometrial hyperplasia. There's no cyclic progesterone if you're not ovulating regularly. And so the estrogen is running wild, just causing proliferation of the endometrium. And then without the progesterone, there's no balance. And so it just leads to the endometrial hyperplasia. So if you do endometrial protection, that helps to balance out the estrogen. And there's a couple ways that you can do that. You can do combined OCPs, you can do progestin orally, or you can do a levonorgestrel IUD. And then for this patient in particular, I liked this question because it's kind of a double hitter. It takes us a little bit back to the one before it when we were talking about contraindications to certain forms of contraception. She is a tobacco user and she has a history of DVT. So for her, we don't want to opt for a COCP. And she doesn't want to be pregnant. And so for that reason, we also are not going to choose medroxyprogesterone acetate because that will help with withdrawal bleeding, but it does not provide contraception. So a levonorgestrel IUD is the choice for her. And then there's someone chose endometrial ablation, which would also be appropriate for her, but as boards often do, the question is what is like the most appropriate management, like the most appropriate next steps. You want to try something that's like a more of a medical solution before you move on to endometrial ablation. Okay, that's it. We'll stop there. And any quick questions that I can address or answer? Probably not. I know we want to stop right at 10:30. Okay. If anybody has any questions, then definitely feel free to email Addie or me because we would love to talk about these things. So thanks.
And hopefully you'll get osteoporosis coverage and an endo talk, or a talk in and of itself. Thanks, you guys.
Yeah. Thanks, everybody.
Thank you, guys. I think actually we
Can
have an
we give
osteoporosis.
the answer? Can we get the answer to the last question just to know?
Sure. The one that we didn't go over. Oh yeah. Sorry, because y'all took the test. Yes. The answer is to discontinue alendronate. Sorry about that. I forgot y'all did it.
I'm giving an academic half day on osteoporosis in January, guys. So we'll talk all about it.
Okay.
Woohoo. So let's take a break here. Thank you so much, Megan and Addie. This was super fun.